All right, well, first, welcome from room 6. Today, this is the first live case, although all the structural cases are done from this room. And that is why this patient who has tower with my associates here, Parusram, and we have two of our fellows here, Mayank and Shiv, and of course, our cath lab nurses and the rest of the staff. So key is, this afternoon, we had two cases lined to show engagement of the coronary arteries, patient post-tower. One was the sapien, which is the real mama case, real one. What I'm going to show is, although this case which I'm showing is the Evolut, but looks like maybe a baby case compared to what Dr. Keeney is dealing with. This is the case number 9, 80-year-old. A patient actually has presented with both angina and dyspnea. And the echo, stress echo was done pre-procedure, and it was anterior ischemia, but stress echo. And then, of course, severe aortic stenosis. So we did the angiogram, and I'll show you that. There was a diagonal disease, 90%, moderate LAD disease. There was anterior ischemia. And we said, you know what, same concept of the complete tower and the CAD examination trials and all, showing that leave the CAD alone and just do the valve. And we did the valve on this patient. Patient did not get any improvement. Continued to have chest pain, and they came to the office again, came with a 1 month, which we do 30-day follow-up, and then came back again just last week having chest pain. We were looking for ideal case. We said, well, let's see this case. But this is more of an engagement point of view. So JR catheter actually rapidly went in, and this is the engagement of the right coronary. So just wanted to give the point. We have a JACC paper 2.5 years ago, the engagement of the coronaries post-tower. So one is the JR catheter. If there is any trouble, then you go with a NOTO. And this is where the catheter sees a nice selective injection. There's some osteal disease, just mild. And look at the leaflet, how does the anterior leaflet is stuck behind, looks like a multiple shadows. These are all the dye going into the crevices of the old valve. See that? And then the left system was the one question. So this is basically the left. So question is, you go with a smaller catheter, whether you the JL30 or FCL30 or EBU 2.5 or even smaller. So key is that you go a smaller catheter. This is just like a Bantal, and this is where we are. We use a FCL 3.5. So we have choice between FCL 3.5 or FL30. Based on that frame, we thought that we probably FCL 3.5 will be okay. And you can see here, it's set very nicely. This is at the osteometer, at the frame, just frame of the core valve, and the valve itself is just below. You see that anytime my catheter is there, it causes moderate central regurgitation because it is preventing the leaflet motion, but it is there. So angiogram wise to that diagonal, you see that very angulated diagonal, proximal LAD was about 50-60%, which looks less now, and this is where we are. So just to say, engagement point of view, the engaging the catheter, angulated vessel diagonal was there. So whole purpose was that we try to see the LAD because patient has anterior ischemia, and look at the long segment of the myocardial bridge. Clearly systolic squeeze. So we felt that the most important is because of symptoms. You're right. Usually our threshold doing a PCI post-hour is to the sky. Really patient has to be acute coronary syndrome kind of. And although it's a big, it's like 2.5 millimeter diagonal, 90-95%, despite the valve working good, the valve area had clearly 1.8. We saw it, there's no paravalvular leak, clearly central, created by the catheter. So we said, let's check from the LAD point of view that where is the trouble. Now, can we see the picture of the IFR? We said we'll decide based on the IFR. Yeah, you see that IFR, the distal to the proximal, pull back. So it is, all the gradient is in the myocardial bridge. At the level of the diagonal, you have becomes 0.95. So there is just, we have shown that actually in our JACC paper. It's not uncommon, it's more IFR actually than FFR. That IFR you can see, there is a clear-cut gradient. It's because of that myocardial bridge. We pull back, and this is where we are at this time, just to show. This is once you bring back the wire, that whole gradient disappeared. Proximally became 0.99. So the key is that this case does have the diagonal disease and ostial diagonal disease. We were able to just use the right guide catheter, is smaller, 3.5 or sometimes actually FL30. Now, can you do it from the radial? We did make a point in our paper that yes, of course, those who are radial expert, and I see a lot of experts there with Nitin Barman, John Fox, which are 90+% radial, probably can do it through the radial also. But we felt that in order to engage, sometimes it's difficult. And I actually have couple of cases where we could not do with the radial and we had to resort to the femoral. But that is just the personal experience and so. But key is that yes, try to use a smaller catheter, long sheath, and that is what we did. Always these cases, you use a long sheath, give you additional support. And this is where we are. And now the rest of the case will be just simple, more interesting. I'm sure everybody wants to go back to Dr. Keeney compared to here. But just point-wise, we wanted to show, we have done the IFR, we are going to do a cutting balloon of the ostial diagonal using a 2.25 and put a 2.5 12 stent. So that is the plan here. If any other questions, any yes, no, and again, just want to make sure that everybody understands this point, that this was done because of patients' very symptoms. Now, we try to advance this cutting balloon, which is not going. See this now? The question is, we do a soft balloon, maybe a 2.0. It is interacting with the, see here. This is the it's a fielder wire in the diagonal. And is it the, give a little die, why? It's a trouble. Yeah. It should go.
Is that stuck on the strut?
Maybe just the, yeah.
On the frame.
It probably at the strut.
On
yeah.
the frame.
Let's get a compliant balloon. So we actually had a choice that we are going to go with the 2.0, 12 compliant or 2.25 our Wolverine. And I was like, kind of little tempted the way everything happened. Wire went into this angulated diagonal very easily. We felt that, it's reasonable.
Do you want to put
go with the 2.25? Yeah.
What about rewiring this?
Yeah.
You wonder.
One is the rewiring. Yeah.
You wonder if the bridge is giving the symptoms also. So.
The other thing is you may need support.
Yeah.
A Godzilla there or a guideliner SS.
Yeah. No. My only biggest problem is that you have something at the ostium, and this is what the challenges you see. It looks like the guide is, we are very happy, guide is there, but no. But again, that could be the effect of our cutting balloon, and if we'll see this, if there is not the issue, if this is still give a trouble, then we'll rewire clearly. Try to go to the maybe different strut or so. No, it went
like
very,
the
this is a 2.0.
I like the idea of a 2.0 compliant balloon.
Yeah, so even but 2.0 compliant may not go because of that angulated. And maybe now we know that this is the case, we could be good for Godzilla or guideliner. Yeah, because of that angulation, this is a floppy wire.
It's the angle and it's a short guide, so it doesn't give you a lot of support.
It's about coaxiality of the guiding catheter.
Yeah, exactly.
Like a regular PCI technique.
Yep.
Looks like you're in the tip of it.
See that?
Yeah, you're in the tip of it.
Yeah. So we are going to go up now.
Yeah. There you go. Nice. Nice job.
Because this, I can tell you every other month, I will have a case which is coming to us from other places. They just cannot engage the coronary. And majority of those cases are from Evolut. Some cases, rare cases of the sapien also does happen. But with the Evolut, not uncommon that I get at least 1 or 2 cases per month because the significant lesion is there and they could not engage it. So now I think we'll definitely
look
try.
how much bigger the vessel's
There was a little
getting.
trouble. Yeah, big vessel. Yeah. So now it explains patient symptom actually. Now what I'm going to do is that maybe the leaflet is obstructing or some way. So at the ostium, where the cutting balloon had a trouble here, I just want to go low pressure here. Will not cause any damage to the left main, but just to align, as Ran said, that maybe we want to be a little more coaxial. Good. Negative now. Going to try that because it's still there is a very significant lesion remain at the ostium. See that now? Still there is a very tight lesion, but big vessel. So all explains symptoms and the persistence. Most of the time, patient after tower, they feel good. They continue to a little short of breath, little bit. We always say, this takes some time and will go away. But this patient has a normal ejection fraction, and we knew about this CAD and positive stress test before. I know there are few of the trials going on at present because very difficult to really determine whether it will be a trouble or not. Complete tower is one of them. But more importantly, you have significant lesion. Should you decide based on the physiological testing? And that's maybe somebody can comment on how they feel about it. To me, I think the physiological testing to make a decision in this tower patient is always a troublesome. Although post-tower maybe not, definitely pre-tower. What we can give and not give. So this does not go. Okay, which is fine. So let's get the Godzilla.
So just to give you follow-up on the radial, we use your same concept of using a smaller guide, even maybe a JR35, but the no-torque catheter also works well. But the JL3 is usually...
But the only problem is that with the JR is still okay, but with the JL, angulated circumflex and LED, it gives very much trouble.
Yeah, no
it just,
support.
catheter, no support.
No support with a
But
JL.
for the straightforward LED, still may be okay, but others give a trouble there.
Sometimes if you get a balloon, you can just kind of bring your guide up and into it, but you have to have something to track over it.
Yep. Okay. So let's say now
It should go.
we are starting. Let's
The balloon now.
You think it will go without the balloon or it will need a balloon? What do you think? Let's predict.
I think you will need the balloon.
No, you need a balloon. Yeah. I mean, same thing. You don't push the guide. As Dr. Kini mentioned also that the pushing the guide is one technique, but that really can create a dissections. And so we use all the cases 45 long sheath, either 25 or 45, and 2 actually gives nice support, and just concentrate on that aspect. And so let's see now. I'm putting the same balloon back,
The same
2O
balloon.
balloon which we had earlier. Yeah. I think it may need a little push here.
It's going.
You go up. So now, once it inflate, we'll telescope the guide. Let's see, it comes now.
Yep. Beauty.
Good. Negative.
Case done.
Negative. Yeah. So now we're just going to put a stent, and if you want to go back,